is also gone.
Yes. Okay, I think with this, let's move on and see some surgical cases of Dr. Rajesh.
Thank you, sir. Thank Malika madam for this kind invitation. I'm not showing a series of patients. I'm just showing one patient and trying to make some sense with my whatever limited knowledge that I have done and surgical experience.
Yes, Rajesh.
Just one second.
Operative anti-VEGF use.
Okay.
So can you see, sir? Can you see
Yeah,
this?
yeah. Please carry on. Yeah.
So my topic is, does anti-VEGF ease out every diabetic vitrectomy? So I come straight to my patient. She's a diabetic, recently diagnosed. When she started complaining of the visual issues, the visual acuity in the right eye was 624 and the left eye was 5/60. So the diagnosis was straightforward. She had bilateral traction retinal detachment in both the eyes, left worse than the right. So this is the fundus picture. You can see the florid vascularization in both the eyes, more so in the right eye as compared to the left. The fibrous component is more so in the left. So with the vision being left less in the left, so we obviously decided with the patient to take up for the left eye surgery. So this is the surgical video. Preoperatively, I have not given any Avastin. Usually, I don't give other than very florid neovascularization, which is very angry looking. So this is my start of the surgery. I'm showing the external profile. I put a chandelier. And you, as Dr. Shobit sir told, so he goes from inside out, but we usually have been trained and I usually more comfortable going from outside to inside. After doing a 360-degree vitrectomy, I couldn't really get a plane, but inferior nasal to the disc, I could elevate the second membrane, and through that, I proceeded with the dissection. So you could see that the membrane is tightly adherent, and majority of the blood vessels are the blood vessels in the new blood vessel, the new membrane was much more thicker as compared to the retina itself. So since the chandelier was in place, I had taken a dual chandelier, so I had started my bimanual dissection with this is a fast forwarded video, so I did very gently, trying to pull at the same time cut and relieve the membrane from the underlying retina. So despite doing however gentle, there were oozing, multiple oozing points. I was trying to deal with it with the bimanual with forceps and scissors, as well as taking the cutter and relieving out the clot in the same time. I usually try to put some amount of PFCL in the posterior pole to make sure that the clot doesn't go into the disc or macula, which might cause further issues while dealing with this clot. So despite all of this, we could see there was a thick clot all around the PFCL adherent to the retina. So this was almost the last piece of the membrane which was pulling the retina, which I could complete. Now coming to the dissection of the clot per se, we could see like it is very sticky. In most of these diabetics, it is quite sticky and adherent. So once, especially when we elevate the pressures and things, it becomes even more adherent to the underlying retina. So using cautery very liberally, trying to clot all the bleeders, whether it was small or large, and try to see whether, because if left alone like this, it would reprolif once, or second, it might cause a redetachment. So these were the concerns, and handling this clot at the end of the surgery was a bit of a difficult. I took nearly about 90 minutes to complete this surgery, out of which about 60 to 65% was the clot management rather than the primary membrane dissection. So I was literally struggling. You could see that the peripheral retina is now getting detached with more of traction. Even the I was getting a bit restless. So more of traction causing and more of peripheral retinal detachment is happening. The clot is also reforming. The hooze is continuing, so the clot is reforming, and the saga goes on like a vicious circle. But by the end of the surgery, I could achieve a fairly good amount of control on hemostasis. But the only problem is I had almost created two breaks in the nasal area, which had caused a bullous peripheral retinal detachment. But to my luck, I had completed the dissection, so there was not much of a problem in handling this. Did an air fluid exchange and completed the surgery. So now this was the post-operative at 2 weeks, and then at 3 months, from directly from 5/60 vision, she skyrocketed to 6/9. She was very happy, but in the same time, I couldn't do the right eye because she wanted the left eye to be stabilized before we took up the right eye. In the meantime, the right eye was getting worse and worse. So what was the lesson learned? I hadn't given any preoperative Avastin. So left eye intraoperative bleed was a big challenge for me. Clot management was challenging. And the amount of time spent on managing the clot was much, much more as compared to the primary membranes. So for the right eye, I decided, okay, let me be, curb my ego and let me go ahead with the conventional teaching as giving bevacizumab at least 3 to 4 days prior to the surgery and then take up for the surgical intervention. So problem was that this was the fundus picture just before the surgery, and post bevacizumab, it got even worse. The fibrous component was much, much more right now. The vascular component was less. So I thought, okay, at least since the blood component is less, so my surgery and dissection will be much less bloodful as compared to the left eye. So I went with the surgery for the right eye right now. And again, the same dual chandler, and the picture is almost the same with a thick plastered membrane all around. And now doing again the bimanual surgical technique. Here I started with superior temporal area, right? Started dissecting. And once I go, you could see that the same amount of bleeders were there because the blood vessels in the membrane was quite thick and it was oozing all around. Despite me putting a PFCL trying to safeguard the posterior pole, the disc and the fovea, it was not yielding. The bleeding was continuous and not stopping at all. So despite that, I somehow could complete the surgery, completed the entire dissection process, removed all the membranes throughout the retina, even completed the peripheral vitrectomy. But at this point, it was like as if the clot around the PSL was so thick and adherent. The person who was assisting me, my fellow, said that I think I should abandon the surgery because it's nearly going to either tear the retina or it will be the same process what the patient ended up with a lesser vision as compared to what we had in the preoperative. But I was not ready to give up. So again, injected PFCL, tried to handle the clot again now. So that was the last pitch of the membrane which was there, and try to attack the clot which was so adherent right now, much more adherent as compared to the primary membrane which was there. The other issue was which I felt was because the membrane was so thick and the preoperative Avastin had curbed down the vascular supply, the retina was much more fragile right now. So whenever I went and tracted and caused a little bit of pull on the retina, it was giving way and causing breaks. Though I had created around 3 breaks in the temporal aspect and 1 in the superior nasal aspect. So that was the last bit of the tissue, the clot and the membrane which was remnant in the superior nasal aspect of the retina. But despite clearing on the other side with liberal cautery, the temporal aspect is again started to ooze. So, and that's the break which I had created in the superior nasal with my dissection. So I continued this process of clearing the blood and the bleeding again, and managing the clot on one side, the bleeder was there in the other side. So the saga of the right eye went on for nearly about 2 hours, and ultimately I could thankfully complete the surgery. So this was the post-operative picture at 3 weeks. The retina somehow attached and nothing much of a event after that. And post-operative, the patient did gain good vision of 660 in that time and yet to siliconal removal as of now. So the lessons which I relearned was preoperative anti-VEGF doesn't necessarily necessitate easy surgery. Do not regress thick formed blood vessels which are there in the membranes. And on the contrary, it increases the fibrosis and the vascularities come down. So the retina is even more, it tears easily, especially in a lasered retina. The lasered areas are much more thinned out and they can easily tear out if you're causing a bimanual and pulling it inadvertently, because obviously we are getting tensed because the blood is too very thick and it is forming a blanket over it. So despite of all the precautions which I could take, which I could with my limited knowledge could take, I was pulling the retina much more than what was necessary, and that was causing tears. So what I really wanted to put it across is the most common and the important factor for an optimal outcome of any surgery is the surgeon himself. Rest of all are just as a corroborative, factors to help you out. Either it might be Avastin, or bimanual surgery, or the newer age cutters, whatever it is. The most important is the surgeon per se, and we shouldn't relax that we have given anti-VEGF and things might be much, much different. Thank you, sir.
Thank you, Rajesh. Must compliment you, all of us, for spellbound seeing your surgery. One of the very nice bimanual under wide angle you showed, and more or less similar picture in both right and left. I agree, but I also disagree that anti-VEGFs have no role. Believe me, there are situations when anti-VEGFs have definitely helped me. So one case does not necessarily decide the fate of anti-VEGFs preoperatively. But I agree that anti-VEGFs obviously will not work in major blood vessels where is oozing, like you rightly said.
I think
But
Rajesh,
but
Can I have a
but
comment?
I am coming back to all the panelists. I know everybody is eager to speak, but what I was trying to tell was the en bloc dissection which you did very nicely and showed patience. What I wanted to emphasize to all the impatient panelists was surgery in such situation requires patience, patience, and patience. Whatever your assistant or nursing staff may tell you, but I must compliment the way you persisted. 2 hours is nothing, believe me, but 6-9 vision is everything. Yes, Shobit.
First I want to compliment Rajesh. His case was absolutely a bimanual surgery case.
Yeah.
But in some such situations where the eye is treatment naive, has not received anti-VEGF, has not received laser, I tell the patient that I will be doing a surgery, primary surgery. I do a bimanual dissection, and when the ooze gets too much, I abandon at that stage. I fill the eye with 20% SF6 and give one anti-VEGF injection. And then I plan my re-entry on the 4th or 5th day back into the vitreous cavity. Things are much better. I then do a cleanup. I remove the residual membranes with ease. And tear formation is less because most of the traction has been relieved in the primary surgery, and then I put in gases. But I counsel the patient beforehand that this would be the procedure I would be doing by choice. But Rajesh has done a tremendous job.
Dinesh, do you do the same as what Shobit said?
no, I wouldn't do this. But Rajesh, first of all, I must congratulate you for your persistence and for showing a video which actually tells us what is the real problem in diabetic vitrectomies.
Thank you,
The
sir.
real problem is this kind of rebleeding during the surgery, which forms a clot which is like worse than the initial membranes. So
Yes.
you have to persist with that. I have at times persisted for 1.5 hours removing the secondary blood clot rather than the primary surgery. So this is one important thing. But one thing is, what I would have liked to do differently, I would, instead of fighting directly, I would not do a frontal assault. What I noticed was that you were delaminating the vascular tufts, the nails directly. I would leave that to the end. I would first go and segment between all these tufts because you can always keep on getting the space in between, and you know that you have a tuft over here, which is going to a nail here, which is going to bleed. So I will avoid it. I will keep on going centrally till I'm able to separate. So I will start from the periphery, then go back to the center, and then from the center go out again from the other side. Once I've separated out all those, and there are multiple nails, but they've not bled yet because I've not touched them, then I will come back to try to do this. And if there is bleeding, even the slightest bit, I will first wait and stop. So that means your surgery you thought was a long time for 2 hours. I would spend 4 hours on the same surgery. Most of the times being spent to stop the bleeding each time it occurs. So this second membrane then is less. So this is what the difference would be from what you did. So you once you decided, you said you just go road roller the whole membrane. It's not possible to road roller the membrane.
So
it will keep bleeding.
So as soon as you see bleeders have to be touched the last. If you continuing en bloc and keep cutting all through, so bleeding will also continue all through and form a sticky membrane. And PFCL, you see, it's a more of a psychological relief that it will stop everything, nothing happens. PFCL does not stop the bleeder at all. Ultimately, believe me, laser also does not. Laser very small.
No,
It's
you have to cut
diathermy. It's
the-
ultimately the diathermy ultimately which will stop the major bleeding. Ultimately, you see, it will not. So therefore, vascular tufts have to touch at the end, and you keep insinuating the probe in between. You will find some gap between two vascular tufts, and keep insinuating. And as Dinesh said,
It's
leave
like
it
a maze.
for the end. And believe me, these tufts, if you segment them and leave them rather than removing the entire end block, you did a very good job in the left eye, and 6/9 visual recovery is not a joke in such patients with such extensive membrane. What was the vision in the other eye? You didn't tell that, right eye.
With the oil insert, it was 660, sir.
Excellent.
So-
Yeah, any other comment by Murli? Yeah.
I think Rajesh, you did a fantastic job, and it shows the trials and tribulations of a retinal surgeon. And I would support what Dinesh said. I would rather do segmentation, quite a bit before trying to remove. That probably would avoid bleeding. And second thing I want to tell you is that I have very low threshold for collecting blood. Moment it starts bleeding, I will not proceed unless I have stopped the bleeding. I keep telling that, the worst enemy in PDR surgery is the blood stuck to the retina. So make sure that you don't have a thick, layer of clot, which is attached to the retina in the first place itself, by trying to spend a couple of more minutes on trying to stop the bleeder rather than allowing it to ooze and then trying to remove the blood. That it becomes more difficult, as you have emphasized. The blood sticks to retina much more than the membrane itself. Membrane comes off easily, but the blood really takes your life out. It's really one of the most difficult situations you have tackled very well. But do not allow it to form is my advice in the first place. Just try keep diathermizing the bleeders. In that situation, I've always found that bimanual surgery helps very well, because you have suction in one hand and diathermy in the other hand. You can actually identify the bleeder and cauterize it very precisely. Otherwise, what happens by the time you take out your cutter and introduce the diathermy, the blood is already loose and you don't know where your bleeder is. In that situation, I find bimanual surgery extremely useful.